First of all, I want to say to Neil and Shak, you two do such a great job keeping this meeting exciting and rolling. It's really fantastic. Really. All right. An 82-year-old nun is referred...
It can only get worse from now, can it?
Yeah, because she's had 2 surgical AVRs and now she doesn't feel well, and she's found to have a moderate VSD right below the second prosthetic valve. That's a tissue valve, and seems to be a significant sized VSD. So the planned procedure is a transcatheter VSD closure using a 10 millimeter Onplots or muscular VSD. So this shows the LV gram, it's a little weak on the dye, but I think you can appreciate here the VSD right beneath the valve. And this shows our loop that we're now dragging down to put in a delivery system. Here's a nice delivery catheter that's not kinking, which is nice, and up goes the VSD device. And now we've deployed 1 disc, and I'm pulling it against the septum. This is the largest we could use without impinging on the aortic valve. And now we're deploying the other side and have a nice waist there. And I had another angio that showed it looked better. The VSD was much reduced, and we released the device. And things were doing great. But we were getting ready to scrub out, and all of a sudden she had her IJ line came out, and she had a rapidly expanding hematoma there that, despite pressure, despite protamine, continued to expand, and she was hypotensive. And the question is, what would you do at that point?
Okay, very briefly, Ilaha, what would you do? Oh, turn the microphone on.
There was a fistula between the artery and wasn't there any fistula formation here during the puncture for jugular vein? You have accidentally punctured, for example, cuts the artery, and there was a fistula or something. There was nothing.
So there was an ultrasound directed placement of a sheath in the right IJ at the beginning of the procedure, because we thought with the VSD location that actually we would be putting in the delivery catheter from the IJ, but it turned out the approach from below was good, so we never used the right IJ.
Ravi? Come on, Ravi. You're falling asleep then. Press the button. Any suggestions?
No, I'm not able to sleep.
No, you can't. Oliver?
Well, I was worrying about an AV fistula as well. But if that's definitely not on, then...
Come on, you're a clinician.
Then I'll stick a finger on it and press.
Yeah, and?
And sit her up.
And check in ACT.
Yeah.
And get some blood. You don't think these are important?
Somebody else can think
You think because you're an interventionist that's somebody else's job, do you?
Yes.
Raphael, you've been very depressed today. This is a nun and has got hypotension after this. What to do?
Yeah, check ACT, make sure that she had protamine was given and the right dose, and compress.
Sorry. Excuse me, did he...
Yeah, hold on.
Or did he hit the carotid? I mean, probably...
Did he hit the carotid?
Carotid, yeah.
And
probably hit the carotid.
Hang on, one at a time. Ravi, carotid? Yeah. Well, he said he did it all with ultrasound guidance,
yeah,
didn't
okay.
he? Yeah.
We didn't feel...
Yeah. So, Elahi, now.
Did you give a fluoroscopy to see what's happening? Fluoroscopy, simple fluoroscopy. When you see what's happening in the chest, everything else is okay. There is nothing in the mediastinum, nothing in the thorax, and everything is okay. Did you
Yep, behind you, yes.
Yeah, maybe a little bit. Probe was fine.
Did the sheath went smoothly when you inserted?
Maybe a little bit weird, but how about device embolization?
Yeah, go ahead.
No,
yeah, sorry.
the device was there, and No, I didn't put the sheath in myself, so I can't say it went in smoothly, but it was done by a colleague who's quite experienced.
Okay, sorry, 3 rows behind. Yeah. Did you want another question or not? No. Okay, carry on, John.
Okay.
Oh, that's impressive.
So, and this only gives half the story. So this will continue to expand, but we did the standard supportive things. She was reversed. She was given fluid. She was typed and crossed. And her pressure was supported. Given this, there was no way we stopped the general anesthesia and the intubation because this was clearly starting to grow to a point that a CT scan just showed this very large hematoma with displacement of structures, and not seen here, but there's an active arterial extravasation from a site that was not clearly seen.
Matt, go on.
I think the concern clearly is an arterial bleed, and the question is, with an ultrasound-guided puncture, they tend to be quite low. So although you're thinking that it could be carotid that you've got, sometimes you can end up with subclavian, and whereas you can push on the neck, you can't really push under the collarbone. So I think a radial outline to monitor pressure and see contrast extravasate in the cath labs may be easier.
Okay, John, carry on.
So, fortunately, we have a cardiac and vascular center, and right next to us are the neuro interventionalists who were quick to say, let's go up and do an initial angiogram off the subclavian of the thyrocervical trunk, and then they saw the inferior thyroid artery coming up here, and they saw this branch, and here there's extravasation out of a small branch coming off the inferior. So what happened? A microcatheter was put in, a 1.2 French. Again, these are neurointerventionalists. 007 a microwire. A super selective angiogram was performed, which again demonstrated what I showed in the angiogram from the thyrocervical trunk. From this location, the branch and pseudoaneurysm were embolized with a 2-to-1 mixture of lipoidol NBCA. What are you laughing about, Neil? Are you used to giving this? So,
no, it's the aphasia I'm finding entertaining.
I'm giving you some excitement here.
I had that 2 o'clock this morning.
Yes. It's what they were serving downstairs in the bar.
Oh, was it lipoidal they were serving last night?
Pardon?
Was it lipoidal they were serving in the bar last night?
So this shows the result of the embolization rather poorly, but this is, it's in a different projection, but basically this glue was injected into this small branch and it completely stopped the bleeding. So I learned a lot from this. This was a complication I've never seen, never had. Hitting the carotid is kind of the days passed without ultrasound guidance, but this was not this. And so, first of all, some equipment issues. These are amazing catheters that the neurointerventionalists have available that are very supple and get very small such that you can really go down these tiny branches. And what's small to us is large to them, working in the neurocirculation. They use a fair amount of glue that's for AV malformations, aneurysms, pseudoaneurysms, and it can be applied for hemostasis for bleeding in other beds. And this substance, mixed with this substance, provides the visibility so you see what it is. And this is a nice little review of the glue and how it comes out, how it's radiopaque, and can be delivered without sticking to catheters and can come out in these large spiral configurations or individual droplets even. So what happened? We had, my colleague liked to call it an aberrant artery branch that just was over the internal jugular, too small to really appreciate with vascular ultrasound, but it got punctured and didn't stop bleeding. And so this is a known, here's your normal anatomy, and so we're used to just worrying about this internal thoracic artery for diagnoses, and consider this a pain in the butt, that there's these other things that our catheter goes into it. But this is routine. A lot of head and neck cancers, et cetera, can have major complications of bleeding. And this just shows the basic anatomy of the internal jugular. It really runs very close to this. And as your point was well taken about being a bit low, you could get into the subclavian, especially with tortuosity in an older person might bring that up higher. But you should be able to see that by ultrasound. There's a big literature out there that as we're doing more and more procedures, like what we're seeing with the coronary sinus-based cinching device, we'll see. And so that really shows some of the art of this. So the take-home points, it is takeoff and landings are key elements of a successful structural heart disease intervention. Know your anatomy that may be beyond what you're normally used to. Ultrasound guidance reduces but does not eliminate complications. We use micropuncture kits too, but that may not have done it either. We learn so much from our partnerships with colleagues. I am standing here at a structural heart disease meeting because I met a few pediatric interventional cardiologists some time ago, Chen Chan and Mark Busek, when I came to Denver, and it really made a difference. And there's an amazing cross-pollination of skills, techniques, technologies, and that's why being in a hospital environment where it isn't kind of siloed and it isn't competitive, but the culture is one of sharing knowledge and participating in cases is, I think, really key. Thank you.
Okay.
Follow up. This
Yeah,
was
John,
very
I was going to ask
disabling.
about the nun.
It stopped, but this took a long time to go away. She couldn't be extubated for another day, and it really set her back such that she took 3 weeks in the hospital to recover from this large bleed.
Okay, all right. Thank you very much. Thank you. We'll move on.